So for stages of labor during pregnancy, there are 3, 4 if you count the afterbirth when you're doing skin to skin. The first stage involves pre-labor, early labor, active labor, and the transition into second labor. And the second stage of labor is basically the pushing phase. And the third would be the birth of the placenta. So going through pre versus early labor, that's when you kind of have the false labor or the contractions that aren't necessarily consistent or progressing, but they're happening. That can be a week before you actually go into labor. And then you have early labor, which is when you start to feel them a little closer together. And active is when they get real close together and they intensify. And that transition is the shortest but the toughest phase of the first stage, where you're getting ready to push. So those are the main ones. I have this in here because I really like this image of how the uterus contracts and how that contributes to dilation of the cervix, which is at the bottom. So you have, these are not the 3 stages. These are the pregnant uterus, not in labor, followed by stage 1 and then stage 2 labor. So stage 1 and stage 2, you're working towards that full dilation of the cervix at 10 centimeters. But notice at the top of the uterus or the fundus, the active segment of the uterus is what's contracting downwards. So a lot of the contractions will create a lot of pressure, and you'll slowly start to feel that descent as the baby drops into the pelvis as you progress through labor. So the goal of stage 1 and stage 2 is to get to that full dilation. And then stage 3 would be to birth the placenta after the baby's born. All right. Okay, so everybody's question about pregnancy and labor is pain. So how do I manage pain? Is it gonna hurt? How bad is it gonna hurt? What can I do for that? The biggest thing that I want to make sure everybody understands is that pain is different than suffering. So pain is defined as an unpleasant sensation and overall experience. It may or may not be physical, because obviously we have some certain things like emotional pain, such as grief and loss. And then suffering is a little different, because that's more of a distressing psychological state, and that may or may not be associated with pain. So pain and suffering, it's kind of like a Venn diagram where there's some overlap, but they're not necessarily the same exact thing, and they're not mutually exclusive. So when you think of labor, we'll go into causes of labor pain. There are definite ways to help mitigate the pain itself, but a lot of that is related to minimizing the amount of suffering, so of the overall experience. And then we have that fun scale at the bottom that we always tell people to rate their pain with, and they're kind of like, I don't know, been there for so long, or I don't know, I'm used to it, it's a 2. So somebody's 2, maybe somebody's 10, and vice versa. So everybody's perception and understanding of pain is a little different. So with labor, most of the pain comes from contractions. Obviously, those can be very intense. You saw how thick the uterus got as you progress through labor. And that causes a temporary decrease in oxygen available to the muscles. So that stiffness, that tension really creates a lot of pressure, and it causes stretching on the tissues of the body. So as the baby descends through the birth canal and through the pelvis in general, places a lot of pressure on the rectum, the pelvic floor muscles, the ligaments, the joints, and the nerves. And you commonly hear what's called the ring of fire, which is one of the pelvic floor muscles that has to stretch a ton during labor. And you can see that in those bottom photos. So they kind of make a sling. So that's part of the levator ani muscle group in the pelvic floor. And as the baby's head passes through, that stretches, I believe it was up to 330 times its original length, based on a computer simulation of a 9 centimeter head. So it stretches a ton. And then some other causes of pain during labor can be emotions. So stress and fear and anxiety can all intensify the pain that's already there, and that can contribute to some suffering. So that's definitely part of it. And then considering any medical interventions that may have taken place. So if you have an IV line or a catheter, if you've had an epidural, some of those puncture sites can become very irritating or painful depending on their placement. So that can be another source of pain during labor. So to manage the pain, it's really important to understand how pain works, because pain actually doesn't get perceived until it gets to the brain. So that's why certain people can do crazy things like swallow swords and walk on hot coals, because it's once the signal reaches the brain that the brain decides that it's painful. So the way that that works is it's carried through the nervous system. So our nervous system is our nerves and our brain and our spinal cord. It's like a freeway that carries signals from all over our body and from our environment. And our brain takes that information and decides what we're going to do as a response. So when you think of the nervous system, you think of fight or flight, or sometimes freeze. And then you have also rest and digest, which is when we are more in a relaxed state, when we can digest food and empty our bowels and our bladder and sleep. So they work in tandem, and there's a balance between the two. So I like to give different examples of how this affects labor, because again, with the labor pains, it's kind of inevitable because the uterus is doing some pretty intense things, and that process is very demanding on the body, but it doesn't necessarily mean that there's tissue damage or that there's any danger. So when your brain perceives danger or a threat through pain, then you can trigger that fight or flight response, and that can also intensify the pain. So some examples like a stub toe I give, because a stub toe, sure, it can hurt a ton, but you kind of saw it happen and you know what you did, and it kind of hurts for a little bit, and you rub it and it goes away. So it's a little easier to process. A gunshot or like a stabbing wound, you sometimes hear people that say they didn't even feel it because of all the adrenaline around that type of injury or trauma, versus a toothache, which you can't see at all the physical damage, but it's almost like as soon as you make the appointment to go to the dentist, the pain disappears. And usually that's because it's associated with a lot of inconvenience. I have to take off work, I have to drive to the dentist, I need somebody to take me home from the dentist, and then I need pain medication. And there's all this stuff that goes into addressing that can cause suffering, but not necessarily change what's happening physically at the level of pain. And then you have amputees who don't have a limb anymore, or even an organ, because I know some research has showed phantom limb or phantom organ pain with like a mastectomy or a hysterectomy. You can have pain in areas of the body that aren't there anymore, because the brain still remembers that that body part was there and it has memories of that area. So pain and suffering, again, they're not the same, but there's a reason why they're so intertwined, because everything goes through the nervous system. So this is going to come in really handy when we talk about how to relax and do pushing strategies next week too. So again, going back to the uterus, I like to tell people pain is a little easier to digest when it has a purpose. And again, pain doesn't always mean that there is something structurally wrong or something being damaged or something being injured. So each contraction brings everybody closer to baby, brings baby closer to the world. And on the other hand, you can feed into the process of what's called the fear, tension, pain cycle, which is when you have some pain from the stretching or the pressure or the contraction, and then there's a fear that, how long is this going to last, and what can I do? And there's almost an automatic response to tense muscles and, almost reflexively, and that tension creates more pain. So it feeds into the nervous system in the opposite way, where you can kind of make pain more intense than it really is because of that fear and that tension. So sometimes going back to what is the purpose of this helps to remind yourself, if you are pregnant or in labor, that there's a purpose for all of this. So it kind of calms the nervous system a little bit to remind yourself of that. So I just described this, but contractions are designed the way that they are, and they progress in the pattern that they do for a reason. So again, it's to dilate the cervix and then eventually push the baby out. And the pressure and the stretching are necessary for the baby to make their way out. So pain is kind of inevitable with labor, but it's not always a sign of harm or damage. And again, remembering that it has a purpose makes it a little bit more manageable. And some of those management strategies include relaxation, breathing techniques, comfort measures. So sometimes people like heat, some like cold, and then support to help decrease the perception of pain. So basically, calming the nervous system helps progress labor, because that's what allows oxytocin to flow freely. And so in that diagram on the side, you see that as the baby drops down to initiate labor, the cervix starts to stretch and hopefully dilate, which that stretch in the cervix stimulates oxytocin to be released. And that causes more uterine contractions to occur, which pushes the baby further down into the cervix, which causes more cervical stretch. So you have this cycle happening for a reason. It's just really long sometimes, and it's really intense. So that's where you want to go back to, is understanding that this has a physiological purpose. So Lastly, pain is driven by perception and it's influenced by past experiences and memories. So if you have, maybe this isn't your first rodeo, maybe you've had a baby before and maybe it didn't go so well. And then maybe the expectation is a little lowered or higher if this is your first pregnancy. So everybody's a little bit different. So management of pain has to address all of those things, not just the physical musculoskeletal system. So this includes physical support. So massage is very helpful. Hip squeezes, if you've seen that in birth videos. Different birthing positions are definitely helpful depending on everybody's anatomy and what they prefer. And we'll go over that next week. And hydrotherapy, meaning hot and cold, also helps. Emotionally, you can use words of affirmation. Hopefully a partner can be there to guide you and coach you through that. Some people like to hire a doula, which I highly recommend. They're great. And then there's also environmental support, which includes kind of taking account what's going on around you. So if you're in a hospital facility, maybe dimming the lights can help, quieting the room, playing some music. I always suggest to patients to bring something that smells like home. So bring your own pillowcases, bring your own blankets, because that really also helps with the stress of everything and getting your nervous system to calm down because it'll feel and smell and look familiar. And then you have medical management, which we're going to get into in a little bit, including epidurals and pain medications that are available. But the bottom line is to make pain manageable, the nervous system has to feel safe and suffering has to be minimized. So however that works for you, that's part of the process of preparing for birth, is to figure out what positions you like and what breathing techniques you like and all of that. So next week, we'll definitely go over breathing, relaxation, breathing positions, and pushing. So keep that in mind. But pain management has to affect the whole nervous system. So medical interventions are defined as anything that does not occur on its own. So this includes IV fluids, fetal monitoring, induction, pain management, medications, etc. So just as a disclaimer, interventions are not bad. Some are necessary and some are needed. And they can be life-saving depending on the situation, and some are optional. So it really is important to understand which options are out there and specifically what options are available at your facility that you choose to give birth in, and to consider the potential risks and the benefits of all of them so that when you're in that moment, you're not having to make a decision based on limited information. So again, not all bad, you just want to know what you're getting into. So the first one we're going to talk about is monitoring. So I have some examples here of fetal monitoring. You can see the external monitor, that's the EFM, and that's on the top left corner where they strap something to your belly. Then you have internal monitors, which you can see below that, where it's attached to the baby's head. And that yellow little wire thing is actually a intrauterine pressure catheter. So that measures the strength of uterine contractions. So that's different than a tachometer, which is also monitoring uterine contractions. And then on the right side, you have the Doppler, which is an ultrasound type of technology where you can externally check the baby's heart rate intermittently. So there's different options, and depending on your facility, you want to know what options are available because they all carry their own risks and benefits. So whether you want to be strapped to something and you want them continuously monitoring you, which can sometimes lead to more interventions because they're constantly watching the heart rate, and can misinterpret, a change in position as a drop in baby's heart rate, and things can get kind of haywire and chaotic, versus something intermittent like the Doppler every hour where they come in and place the monitor on your belly. And then you have tools that help with extraction. So Linda talked about episiotomies last week, which is when they make that incision at the perineal body. And so that's something that is sometimes necessary when you're using things like forceps or a vacuum. So that creates more space to get those tools in there. Hopefully you don't need these, but sometimes under an emergent situation where maybe the baby's in a little bit of distress and they need to get the baby out quicker, they may need to use some of these tools, and episiotomy would help place that a little bit more accurately. Otherwise, episiotomies are not recommended. And then the indications of all these on the pelvic floor is depending on what interventions you have implemented during your labor, that can limit your mobility and your ability to use different comfort measures. So imagine being wired to a machine and not being able to hop in a tub or a shower or use the restroom freely. And then they may prolong labor because of that. So just some things to consider. And then the epidural. So I have an image here because I think a lot of people don't understand what getting an epidural looks like. And it's a very long, thin needle that goes into the spinal column. So you can see that on the right. What that requires is for the person to be very still and in a kind of hunched position. So this person's sitting, but some people do them, some radiologists, anesthesiologists do them with the patient lying down. So it does take 30, 40 minutes depending on, the person. And if your contractions are really close together, that can be very difficult to hold still. But you need to, because you can tell it's going into the spinal column. So you don't want to puncture anything that you don't mean to. And then with this, your blood pressure is monitored every 15 minutes. So that can be a little annoying to some people who want to rest during their labor. But depending on your facility, they may have a walking epidural available, which means that you don't get completely numb from the waist down and you can still move around a little bit. It may or may not stop the pain completely. Each facility doses it differently, so that's a conversation to have with your OBGYN. But it is a great intervention for some people, and they'll say that it saved them and they loved it. Some people didn't work so well, or it was really irritating at the puncture site. So just some things to consider. The implications of this on the pelvic floor is that, again, if it's not a walking epidural, then you would be limited in your ability to move around and use different birth positions. And it may limit your ability to push effectively if you do go completely numb from the waist down. So it's also associated with prolonged labor and sometimes an increased risk of C-section. So again, things to consider. Everybody's a little different, but it can be very comforting to have this. And if you're the type of person who knows you don't do well with pain, then you want to definitely consider it and do some research on it. I think the last one I have here is Pitocin. So Pitocin is commonly used for induction of labor. So it's administered through an IV, and it will require multiple forms of monitoring, and that includes for you and the baby. It may also limit your ability to move, eat, and drink if eating and drinking is allowed at your labor. But it does also help to control bleeding after birth. So Pitocin is commonly administered after the baby's born to help clear some of that, or to help minimize some of that bleeding after baby's out. Implications for the pelvic floor include that it typically leads to more interventions because obviously there's more monitoring that has to go on. And because it brings on a hard and fast labor, the contractions are a lot more powerful, and that can make labor more challenging because they no longer follow that gradual progression of starting a little shorter and further apart and then getting more intense and closer together. It's kind of just depending on the dosage and depending on your physiology, how it affects you, it can make labor a lot more difficult. So pain can be a little bit more challenging to deal with Pitocin. I should also add that with the epidural, you will be catheterized. So that's when they put a little tube, a very flexible tube in the urethra to constantly drain the bladder. So that's required for any medical procedure or surgery, but because the epidural takes away your bladder control, they need to make sure you're not retaining urine during that time. So when Linda talks about postpartum urinary symptoms, sometimes the catheter can have some implications and some contributions to that. So keep that in mind. All right. For cesarean sections, I really like this picture because that little baby looks so grumpy. But Linda talked a little bit about C-sections and how that affects postpartum. But just to give you a general understanding, they are a medical procedure. They're a surgery, so they're performed in the OR, not in the delivery room. They require pre-op preparation and anesthesia. And the implications on the pelvic floor include, if it depends on if it was an emergency and if it was just from prolonged pushing that they decided to do the C-section because it's been so many hours and, baby's in distress, depending on what the indications were for the C-section. If you had labored already or attempted pushing, you can still end up with a couple of different pelvic floor symptoms afterwards. And the healing process is longer because of how the abdominal wall has to heal from that. And changing the abdominal muscle tone and strength and having to recover there definitely changes the demand on the pelvic floor muscles. So there can be some implications for that. And lastly, the scar tissue that forms, which Linda already talked about last week, it's right above the bladder, really low in the bikini line, and it's the formation of that can cause some adhesions around the internal organs, so including the bladder, which can affect bladder emptying, bladder filling, and bowel movements as well. So once again, I just wanted to circle back to pain management because the purpose of all of those interventions are sometimes to make pain more bearable. But pain can be bearable if you understand what's happening, because the side effect of a lot of those medical interventions is that the natural pattern and progression of labor changes, and it can be a lot more challenging. So they can help, but they can also create a disconnect between what your body is doing and what your sense of control is with that, especially when it comes to pushing, which we'll talk about next week. And then going back to that fear, pain, tension, or fear, tension, pain cycle, the side effects of different interventions can make labor more uncomfortable and limit your movement. And if you're uncomfortable, you tense up more. And then if you tense up more, oxytocin can't flow freely. Maybe you have more stress hormones in your body, and that can contribute to more suffering. So again, going back to pain versus suffering, thinking about if the goal is to just completely get rid of pain, it's not always guaranteed with interventions, but it can definitely make you more comfortable, but not without some consequences. So understanding and choosing what's right for you and understanding how you perceive and move through pain is going to be very helpful. All right. So the last thing I want to talk about is decision making. So informed consent is huge for all those medical interventions and with all of the labor process in the hospital, especially with everything going on with the virus. So a lot of things are changing. So definitely call your hospital if you're pregnant and expecting, to see what their policies are and how those things are changing. And advice that I got from a local doula group was that you should call really every week, multiple times a week, because they're constantly changing the regulations. But anyways, informed consent is defined as the process of communication between a patient and a physician that results in the patient's authorization or agreement to undergo a specific medical intervention. So this requires a few things, which we'll talk about, but ideally it would end up with conscious agreement, which is the act of making a decision based on your inner listening and your intuition. So a decision that's aligned with what you feel that you need, that you make within yourself, given proper information from your practitioner. So what's required of informed consent includes what intervention is being offered and what it would involve. So if it was an epidural, do you want to get an epidural right now? Well, what does that mean? Oh, you're gonna have to lay down for 45 minutes and they're gonna puncture your spinal canal and insert a needle, and then we're gonna hook you up to an IV, and then we're gonna put a catheter in, right? It's important to know all those things because it affects how you're gonna labor. And then knowing the associated risks and benefits of the intervention that they are proposing to you, as well as what are your alternative options and the risk and benefits of those. And one of the alternatives, usually under normality, meaning there's no emergency, is doing nothing, right? Oh, you want some Pitocin to speed up the labor contractions? Versus, oh, what are my other options? Well, we could just not do that. So depending on how you want to approach your labor, it's good to understand how to go about giving somebody informed consent and knowing what questions to ask so that you can make the best decision for you. Because again, unless there's an emergency, the best course of labor is it knows what to do. Your body kind of knows what to do. So depending on what your priorities are, so if it's pain management or if it's not pain management and it's you want to move around and be comfortable, understanding how this process works will help you communicate with your staff when you get to that point. Informed consent should not be, it's not a signed form or a document, it's a process of communication, and it shouldn't be the result of coercion or threat. So if, you gotta watch people's language. If they say, oh, well, baby looks like, baby's kind of big, we should consider, just doing a C-section. Right? You need to ask, well, why do I need that? What are the risks? What are the benefits? And what's the alternative? And what happens if I do nothing, if I don't do that? So I think this is a very important slide for a lot of people to really feel like they're their own advocate. And the purpose isn't to make anybody defiant to medicine or defiant towards physicians or their OBGYNs. It's understanding your options and understanding how to have a productive conversation about how it can affect you in the long run. Because all these things that happen throughout labor can affect your pelvic health in postpartum. So that's why it's important. So again, I like this quote, the power of a birth plan isn't the actual plan, it's the process of becoming educated about all your options. So I think that's all I have. Yep.